Welcome everyone to the 2025 Benefits Compliance Highlights and Recap. Thank you all so much for joining us. The Benefits Compliance team will be answering the questions you send through the Q&A today. We'll try our best to answer all of your questions, but if for whatever reason we're unable to get to your question today, please follow up with your advisor for further assistance. Today's presentation is being recorded. We will be sharing the recording in the follow-up email and on the NFP website. If there are any portions of this call that you missed, by Monday, you will receive an email with a link to the full recording. The PowerPoint slides used during this presentation will be shared in the same email. At this time, I'll hand it over to the Benefits Compliance team. Kelly, the floor is yours.
All right, thanks, Amber, and welcome everyone, and thank you for joining us. I know it's probably a busy time for many people as we're in the midst of the holidays and sort of wrapping up the year end, so we appreciate everyone joining us for this recap of 2025 and then looking ahead to some hot topics and trends for 2026. And so here is a view of our smiling faces. Instead of just getting two of us, you are going to get our entire kind of what we call our core team, our benefits compliance team. So here are our smiling faces. And as you may have noticed, you get to see us on camera today instead of just our names. So putting those faces and voices together. Now, before we get too far into this, we always like to have a reminder that the information we're covering today, this is general guidance purposes. So we're not giving legal advice or tax advice today. If you do have questions of legal nature, you need to address those with your own legal counsel or tax advisor. And the information we're talking about today is current as of today. And you'll find out a little later why some of this is changing potentially day by day. So what are we going to cover today? So again, we're going to start with those highlights. What are some of those topics in 2025 that are helpful to kind of revisit and keep on your radar? So we're going to look at some of the various updates from legislation this summer, what we affectionately call OBUBA, or the One Beautiful Bill, Big Beautiful Bill Act. I always miss one of those B's. We're going to look at some state updates and reminders. I know this is a topic that is something that is top of mind for a lot of you. And then we're going to look at some mental health parity updates. And then we're going to look at 2026. And so we're going to look at some trends and hot topics to consider. So we're going to look at healthcare price transparency rules, and then look at some predicted agency guidance and kind of what to think about from a political landscape in 2026. And then we will finish up with some year-end housekeeping reminders. So we're going to get started here, and Sharon is going to kick us off with some tax account updates from that recent legislation.
Thanks, Kelly. We're going to use all kinds of letters today. So I'm going to talk about direct primary care service arrangements, or what are known as DPCSAs under the OBBBA. So this law does two things. First of all, beginning January 1 in 2026, certain coverage under DPCSAs will no longer disqualify an individual from contributing to an HSA. And the law also provides that certain DPCSA fees are qualified medical expenses for purposes of an HSA, and can be reimbursed on a tax-free basis under an HSA. This is a shift from the earlier IRS proposed regulations, which generally treated these types of arrangements as incompatible with HSA eligibility. So Congress has basically stepped in with a statutory definition to give clearer boundaries and to make these arrangements workable alongside of HSAs. So what exactly qualifies as a DPCSA? Well, this is an arrangement where a person pays a fixed periodic fee, usually it's monthly, for primary care services only. These services are delivered by a licensed practitioner, like a physician or a nurse practitioner. And the law is very intentional about its scope. So it's routine outpatient care. It does not include services requiring general anesthesia, most prescription drugs other than vaccines, or lab work that would fall outside of typical primary care setting. And there's also a fee cap. So for an individual to maintain HSA eligibility, The fee can't exceed $150 of self-only coverage or self-only for or $300 for a family, and there is annual indexing. The IRS recently issued some guidance and it clarified that this limit applies only for purposes of HSA eligibility. If the fee were to exceed the limit, the individual will not be eligible to make contributions to an HSA for that month, but the HSA could reimburse the higher fee as a qualified medical expense. I want to draw quickly a distinction between concierge medicine and DPC services because they sometimes get lumped in together. So concierge medicine is typically charges a higher annual fee for enhanced access to care. By contrast, as DPCSA is narrowly defined to primary care services. And the fee is capped and it's a fixed fee as the practitioner's only compensation for primary care services. A label alone is not determinative, so the arrangement has to actually meet the statutory requirements. I like to think of these arrangements and these issues really as employer plan adjacent. It mostly impacts individuals and their HSA eligibility rather than the employer or the employer's HDHP. An employer is not responsible for monitoring whether an employee has a permissible or impermissible DPCSA coverage, but the employer can help educate employees and help them understand which things would disqualify them from contributing to an HSA or which expenses might be reimbursable under an HSA. So the big picture is that Congress created a pathway for people to pair direct primary care with an HSA, but they kept the definition pretty tight to avoid opening the door to arrangements that look more like comprehensive coverage. All right, let's go to the next one here. Yep. Individual coverage and HSA. So starting January 1 of 26, bronze and catastrophic individual plans, whether they're purchased on or off the exchange, will be treated as qualified high deductible health plan coverage for purposes of an HSA. So this would apply again, regardless of the plan's deductible or out-of-pocket max. It expands HSA eligibility to individuals. Employers can contribute to the HSA of employees enrolled in these plans. It's especially relevant for employers offering individual coverage HRAs or ICHRAs. It broadens the pool of employees who can receive employer contributions. One key nuance is that ICHRAs cannot reimburse, can only reimburse premiums for off-exchange individual coverage, but not for plans purchased on the exchange, and this rule did not change. Employer HSA contributions, including those made via salary reduction through a cafeteria plan, are going to be subject to the non-discrimination rules of Section 125. If it's made outside of the cafeteria plan, it will be subject to the comparability rules. And employers with ICHRAs are going to, if they want to implement this, should speak to their vendors, are going to need to update their plan documentation, talk to the payroll systems, employee communications to incorporate the new eligibility and contribution options. All right, let's move on to our next thing. Sorry, that is the permanent extension of telehealth for HSA safe harbors. This was something that had been in place prior to the beginning of this year, and it sunset or expired, and the OBBBA just re-included it back in here. So some employers had dropped that coverage, telehealth coverage for purposes of HSA eligibility, whether or not it impacted it. And others just kept the law in there or kept the rule in there because the idea was that Congress was going to re-implement it. So Congress did. It took effect in January of this year. And some employers may have held off from implementing it. And if they're doing it for this coming year, they would need to speak with their carrier, the TPA, and implement, the language in their plan documents, update the SMM and all of that to re-include it back in there. So if we take another minute and step away from HSA coverage and we think about DCAPs, the law also increased the maximum annual DCAP or dependent care plan exclusion this year coming up on January 1st. The maximum amount that can be excluded under a DCAP is increasing from $5,000 to $7,500 and from $2,500 if you're married filing separately to $3,750. This amount is not indexed. It's just a set amount. Employers are not required to adopt the higher compensate, the maximum contribution. There may be some reasons why they won't want to do it. These plans tend to be what we call top heavy, which is they get a higher number of highly compensated individuals participating in them, and that could be due to a lag in reimbursement. So for a lot of these fees related to dependent care, someone might have to pay for the service up front, like at the beginning of the month for a daycare center, and they are not able to be reimbursed for that until the services have been provided, which is a DCAP rule. And so we tend to get a higher paid person participating in this plan. So we recommend if an employer implements the higher rate to run non-discrimination tests early, to put in, a campaign to try to enhance the benefit for individuals that are lower paid to participate and increase that participation. Let's go to our next slide. So we are still getting some questions because there was some publicity about things that were in the bill or going to be in the bill, and they may have been in this bill at one point, but they actually never made it up into the final bill. And we just wanted to clarify some of those issues here. So there have been no increase in contribution limits to an HSA. Those things are annual. They're tied to your HDHP coverage. They index as usual. There's been no increase in that. The HSA and FSA enhanced rollover expansion did not come to fruition. So those carryover and grace period rules, they remain unchanged. With regard to qualified medical expenses, fitness costs and gym memberships and other sort of wellness expenses are generally not qualified medical expenses. Nothing has changed with regard to that. There can be instances where they are prescribed to help with a specific disease or health condition, like if you've broken your leg and you need to do some rehab for that or physical therapy. They might be qualified medical expenses, but nothing has changed with regard to those. And there have been no changes in what isn't considered impermissible coverage with respect to a spouse having a health FSA, a general purpose health FSA that will still disqualify an individual from contributing to an HSA under their employer plan. Medicare Part A remains disqualifying coverage, and on-site clinics will also be disqualifying coverage unless the coverage is limited to permitted care like preventive care. And with that, let's head over to a state update.
All right, thanks, Sharon. Yeah, we're going to move into our state updates. And first, Patrick is going to take us through just some quick state reporting reminders.
Thank you, Kelly. As everyone may recall, the ACA, when it was enacted, has carried within it an individual mandate, which required individuals to obtain coverage or pay a penalty. However, starting in 2019, Congress had reduced the penalty for failing to meet the mandate to $0, effectively rendering the federal individual mandate, toothless. However, a handful of states have taken up that call and imposed their own individual mandates, requiring residents of those states to have coverage or pay a penalty. Those states include California, Massachusetts, New Jersey, Rhode Island, Vermont, and the District of Columbia. Employers are generally speaking obligated to report to those states whether or not their resident employees have coverage. And the reporting to do so, they can usually submit the federal forms, those 1094s, 1095s that they're already generating for the federal. At the federal level, they can submit those to those states as proof that their residents are indeed getting coverage. Now, something important to point out here is that, as you may know, this year in 2025, the federal government gave employers the choice of either furnishing those 1095 forms to employees upon request, subject to some requirements, or furnish those directly to them as usual. However, um, each state's individual mandate still generally requires employers to automatically distribute those coverage statements to employees, regardless of any request to do otherwise, and to submit reports to state agencies by specific annual deadlines. So the option to post those or furnish them on request don't trickle down to the states. At the state level, you'll still have to furnish those actual forms to the residents of those states as well as to the states themselves in order to evidence that the resident employees are actually getting the coverage required under those states. So if you have a fully insured plan, typically the carriers may be doing that for you or on behalf of the employers, but it's always a good idea to check with the carriers to make sure they're actually doing that. And if you are a self-insured employer, then the employer itself is responsible for making those or filing those forms and showing that their resident employees are meeting the mandate. And we have an excellent publication, the State Individual Mandate Reporting Requirement publication, that goes into much more detail about these requirements, what needs to be done to fulfill them, and when those filing dates are. And so that wraps up our individual mandate reporting requirement section. So I'll pass it back over to Kelly to talk about some more state requirements.
All right, thanks, Patrick. Yeah, definitely. If you haven't taken a look at this publication and you have employees in these states, definitely request a copy of that from your consultant or advisor because it has a lot of helpful information for those requirements. And so now, sticking in the state realm, we are going to take a look at some state PFML updates, and Molly's going to take us through that.
Hi, everyone. All right, so it's always a good idea to take stock of where we are with state paid family and medical leave laws and requirements because that is a constantly changing, constantly evolving area. Seems like new states are being added, colored into this map here every single year. So here's the kind of snapshot of where we are right now. The states that are colored green have a paid family and medical leave requirement. So that means that, employees can take it if they have a serious health condition for themselves or if they need to take care of a family member, for example, after a birth. Hawaii, however, just has the disability piece, which means, an employee's own serious health condition. Vermont and New Hampshire, they have an asterisk here because they're not required for private employers to adopt them. They are optional programs that employers in those states or with employees working in those states can opt into. Okay. So looking ahead at 2026 and beyond, we do have some state programs that are rolling into place. So if you have employees who are working in Delaware or Maine, hopefully you've already started paying into the system, whether you're doing payroll deductions for the state program or you have an approved private plan that will provide that benefit. Benefits are going to be starting January 1st. That means that employees can go ahead and apply with the state or with your policy for eligible leave in those two states. Maryland, poor Maryland, they have a family program, a PFML program that has been delayed and pushed back a few times now. It was supposed to go into effect starting in 2026, but now we're at contributions starting January 1st, 2027. So you have another year there with benefits starting January 3rd of 2028. So that's where we are right now. Stay tuned on Maryland. Minnesota, in Minnesota, I don't know if it's just that they're extremely nice or very, very excited about getting started with their PFML program because they have both contributions and benefits starting January 1st, 2026. Usually you see a lag there between the two, but in Minnesota, make sure you are ready to go. All right. So all of the states that we just looked at on the previous slide have now updated their 2026 contribution benefit maximums, notices, all their information for 2026 has been updated and put out there. And we definitely advise you to check with each and every state where you have employees working to make sure that you are aware of any and all changes. You'll want to make sure you update your leave policy, work with your payroll vendor, or if you have a leave management vendor, if your disability carrier is handling it for you, make sure that they are aware of the new figures that are in effect for 2026, as well as new notices or posters that have to go to employees who are working in those states. So generally, it's a good idea to have an action plan when it comes to state mandated leave and your leave program in general, right? We do recommend that you establish a company leave policy that addresses all facets of employee leave, whether that be the mandated state PFML program, the unpaid job protection under FMLA, and an internal leave benefit policy that you may want to implement in addition to what is required under state or federal law. The STD and LTD program that you might have, etc. It's a good idea to really think about that holistically and try to make all of those pieces work together. All right. Also remember that some state PFML programs provide job protection and employee benefit continuation. For example, New York and Colorado do. Other states do not, though. All they provide is the income replacement without the job protection piece. That would usually that comes from another state law that is like the state FMLA version, kind of. All right. So if you are an employer with employees in multiple states, especially the states that were on that map that we just looked at on the last page, then we realize that you are facing a lot of challenges when it comes to making sure that you are complying with all the pieces. We definitely think that you should, again, take a look at your policy as a whole, work with your disability vendors and your payroll, and consider maybe even, if things are getting really complicated, using a leave vendor to help you out with all those requirements. All right. And then we have a publication. It's a quick reference chart. It's kind of a short, simple piece that lays out all those states with the basics of what their PFML program requires and involves. And that is hot off the presses as of yesterday morning, with all those new 2026 numbers. So please make sure you reach out to your NFP account team to get a copy of that publication. Thank you very much.
All right. Thanks, Molly. Yeah, the state, I know we've covered the state items in, webinars previously. Even this year touched on bits and pieces of it recently, but it's definitely a topic that we get asked questions about all the time, and it's always one of the ones that people are still saying that, you want more information in webinars. So hopefully you find that useful and you've taken a look or requested that publication, because it really is a great resource. And so now we're going to leave state updates, and we are going to go to some mental health parity updates, and Sarah's going to take us through that.
Thanks, Kelly. Yeah. We're going to talk about MAPIA, specifically the non-quantitative treatment limitation comparative analysis. Not easy to say, not easy to complete. And it's been a recurring topic for us for the past few years because it's been an enforcement priority. It's complicated. It requires a lot of cooperation with carriers and TPAs, some of which have been reluctant to step up. So it's a requirement that continues to put us and all of our clients in a tough spot. We could spend all day talking about MAPIA, but obviously we've got loads of other topics to cover this hour. So we're going to just go quickly through some of the 2025 developments and then point to our resources for more information. So quick recap, the Consolidated Appropriations Act of 2021, the CAA of 2021, as we call it, it introduced this new NQTL comparative analysis requirement. So an NQTL, that's the acronym for non-quantitative treatment limitation. Things like coverage exclusions, prior authorizations, medical necessity guidelines, network restrictions, really any coverage limitations that can't be quantified and easily compared. And plans and insurers need to actually document NQTL compliance through what's called a comparative analysis. That's what the comparative analysis is. And that has been in effect since February 2021. Basically, the comparative analysis, I like to think about it. First, you have to identify each mental health NQTL and then justify its inclusion in the plan. Justify by showing that it's somehow comparable to and not applied more stringently than similar medical coverage terms. So there's no requirement to annually submit the comparative analysis, but plans, employers, sponsoring plans, and insurers need to have it on hand to be able to quickly reply to any request from a federal or state agency or a participant or plan beneficiary, which we think would be more likely. So in 2024, we had final rules, and we talked about these last year. Those final rules from 2024 added a few new requirements. The first was the meaningful benefits requirement, and that requirement was that a plan needs to provide a full range of treatments for mental health conditions. The rules refer to these as core treatments. The final rules from 2024 also require plans to look at outcomes data to address differences in access to mental health benefits, again, as compared to medical benefits. So those two requirements really relate to the details of the analysis. I think more relevant to employers that aren't actually completing the analysis, which is fewer actually completing. Most have their TPAs do it, or perhaps a vendor do it. But for all employers, the final rules added, or all ERISA employers, the final rules added a fiduciary certification, requiring a plan fiduciary to sign off on the analysis. So that really felt more like a formality. I think regardless of any specific certification requirement, ERISA plan sponsors, they're still fiduciaries responsible for making sure that the analysis is completed and that overall the plan is in compliance. Okay, let's move to this year. So in January, the ERISA Industry Committee, so the acronym they go by is ERIC. ERIC advocates on behalf of large employers. They filed a lawsuit challenging those 2024 final rules as going beyond the tri-agencies authority, the tri-agencies being DOL, HHS, and IRS. Eric took particular issue with two parts of the final rules. The first is that meaningful benefits requirement that I just mentioned, right? The requirement to include core treatments. And then the second was the requirement to look at outcomes data. So Eric's argument, one of their arguments was basically that the MAPIA statute doesn't mandate any particular benefits. It only requires parity in the plan terms and application, not parity in outcomes. So that's how they were challenging those two requirements, the meaningful benefits and the outcomes data requirement. They also claim that the final rules are so confusing, so unworkable, so burdensome that they would lead some employers to not offering mental health benefits at all. Because remember, offering mental health benefits in the first place is not mandated under MAPIA. It's only that if an employer, if an insurer plan offers mental health benefits, the coverage terms need to be comparable to, meaning at least as good as medical benefits. Along with the litigation, Eric sent a request directly to those tri-agencies requesting that the implementation be put on hold. And on May 15th, the agencies did just that. They put enforcement of those September final rules on hold while the lawsuit is pending, and then for an additional 18 months. So a long time. In putting those rules on hold, they noted that they're still considering whether to pull back or modify the rules because they are concerned with the burden that it places on employers. However, they were very clear that enforcement on the underlying requirement, right, that comparative analysis that went into effect in 2021, it is still in effect. And I checked the docket for this lawsuit earlier today. There's nothing new to report. The last was a status report from the government saying they're still considering whether to pull back or modify the 2024 rules. Kelly, can you go to the next slide? So looking ahead, even if these rules are ultimately withdrawn by the agencies or they're struck down by the court, the comparative analysis is rooted in the CAA 2021, and it would take so rooted in statute. So it would take an act of Congress to actually amend that statute. And we've seen bipartisan support for access to mental health treatment historically. So we don't, at least at this point, see that that's going to happen. But we do expect that there are and there will continue to be fewer resources for DOL investigations and possibly MAPIA investigations specifically. But there is the continued risk of participant litigation. That hasn't changed. And so often the participant litigation includes penalty claims for failing to provide a comparative analysis within 30 days, along with other plan documents. So can't just ignore the comparative analysis requirement. The general steps towards compliance haven't changed with the pause in the final rules. And really, with one exception, I guess that would be the fiduciary certification I mentioned. But that's really not a new substantive requirement, it's more of a formality. So for next steps, MAPIA compliance is going to continue to be a real challenge. This year, we released an updated employer guide on the NQTL comparative analysis pictured right there to help. It's got employer action items based on whether you're fully insured or self-insured, tools for working with your TPAs, guidance on selecting a testing vendor if needed, guidance on assessing risk, including certain red flags, and that's that second publication image right there. It's really important to be attuned to red flags and see whether they need to be removed from a plan. And by red flags, I mean things like exclusions for ABA therapy for autism, certain restrictions on out-of-network benefits just for mental health. But there's a full list in there for you to review. And, we always like to say that employers should pay attention to participant complaints because they signal trouble. They often signal trouble. The DOL isn't picking plans at random to investigate. They're driven, they're triggered by these complaints. And they also signal a risk of a lawsuit, right? Not only a DOL investigation, but a participant lawsuit is going to start with a claim denial and often a complaint to the employers behind that. So those are our resources. Please ask, your NFP broker or consultant for a copy of these. That's it, Pia, Kelly.
Awesome. Thanks, Sarah. Yeah, definitely a topic to watch. Seems to be every year we're kind of keeping an eye on it. So it'll be interesting to see what 2026 brings us for MAPIA. Sure. And so now we're going to switch gears and we're going to kind of look at, we've covered what happened and some of those hot items in 2025. So now we're going to look ahead for some things to kind of keep on your radar as we head into this next calendar year. And so first, Carol's going to lead us off into some healthcare price transparency rules and what to look for in this coming year.
Thanks so much, Kelly. And yeah, we're gonna take a step back, and good afternoon, everybody. Take a step back, and then we're going to move forward. Healthcare price transparency and the related rules we know has been a hot topic in recent years. We expect it to continue to be. And just maybe we should define it first. What we're talking about with healthcare price transparency is this concept of ensuring that consumers, which include plan sponsors, have accurate, complete, and meaningful data so they can make informed decisions about healthcare benefits. And armed with this information, they should be able to negotiate better prices for their plans. This in turn creates a more competitive market and overall will lower prices, lower healthcare prices. So that's really the idea behind it. Of course, and related to this is that the data is so critical to our plan sponsors because they, as fiduciaries, have an obligation to make sure that they're prudently using their plan assets and selecting and monitoring their service providers. So why is there such a heightened focus on healthcare price transparency? I think the obvious reason is that the healthcare prices and particularly prescription drug prices, they've continued to rise. We haven't seen a lowering of the prices yet. So, pharmacy benefits have been a particular focus, our weight loss drugs, the GLP-1s. Of course, they're used for other purposes as well, but also cancer treatment drugs. And while the drug market is complex, it's certainly believed that a lack of transparency, opaque contracts, are a contributing factor to these prices. Uh, Fortunately, the Trump administration does view healthcare price transparency and lowering drug prices as priorities, which is interesting, right? They're largely deregulatory, but they've zeroed in on healthcare price transparency. The administration's issued two executive orders this year. The first issued in March, and we'll use the short name, Making America Healthy Again, called for action to improve and enforce existing price transparency laws. And for group health plans, specifically, the order asked the agencies to issue guidance to fully implement and enforce the transparency and coverage rule. Now, you, as plan sponsors, are all familiar with this. This brought us the requirement to post machine readable files for our in-network rates and out-of-network allowed amounts. But what you may have forgotten is there was also a requirement to post prescription drug prices. That was never actually implemented due to litigation. We believe the guidance that the agencies are going to issue will focus largely on that and also on just more accuracy in the data that's already being posted. And this data is very important. I should share with you. It's not useful directly to employers, but the data analytics folks have been able to take the MRF data and incorporate it into useful tools for plan sponsors to compare prices. Much more useful than our RxDC reporting data and all to getting to helping plan sponsors. So that's the first order. The second one was aimed at lowering drug prices by increasing competition in drug markets. The order itself was broad. It called for, looking into increasing imports of drugs, to streamlining the drug approval process. But for group health plan sponsors, it asked the DOL to propose rules to help sponsors understand the compensation received by their pharmacy benefit managers, to propose rules that we know that employers as plan sponsors have an obligation to receive and review disclosures from their group health plan service providers regarding their compensation. That was part of the Consolidated Appropriations Act of 2021. These are known as 4AB2 disclosures. So we're going to be seeing guidance there in response to the order. The focus is also on healthcare price transparency is also due to class action litigation against group health plan sponsors. The most famous case is the Johnson & Johnson case. That was the first. There are others, the Wells Fargo case. And in this litigation, the participants are alleging that the group health plan sponsor has failed to negotiate competitive pricing for their plans. And with their service providers, they're essentially paying too much in fees, particularly for pharmacy benefits. Now, thus far, all of the claims in these cases have been dismissed. That's good for plan sponsors because the participants really couldn't draw a link between the high prices and their premiums and cost sharings. They couldn't draw a link that they were really harmed by the employer's actions, but still something to monitor. And we've also seen a lot of state PBM legislative activity, and this is looking to regulate the activities of pharmacy benefit managers and their practices for their residents. In some states, Arkansas, more recently California, they've been pretty aggressive with that. Next slide. So what will happen next? Well, employers should expect, this is very important, significant healthcare price transparency rules to be proposed and released in the coming days. And this is in response to the Trump executive orders, and these will impact your group health plans and your compliance obligations. And we really see this as imminent. So this could be within the next week, maybe not the holiday surprise that you're looking for, but you should be aware of this. The agency guidance will likely address the transparency and coverage rule, that prescription drug MRF posting requirement, and perhaps a timeline for implementation. And the rules will also address the PBM compensation disclosures and hopefully also provide broader guidance to health plan fiduciaries regarding how exactly they should be prudently selecting and monitoring service providers. Yeah, we're hoping that this legislation is really going to be helpful for plan sponsors and give us that guidance so they know what to do to fulfill their obligations. Unfortunately, we expect the litigation against plan sponsors will likely continue. It's something to monitor. Class action lawyers will probably come up with new legal theories. But there is some good news in that the new DOL secretary, he's pledged to end ERISA litigation abuse, these meritless claims against plan sponsors. And the Trump administration seems to be supporting that. So I think that's a positive development. On the state PBM fronts, we expect that activity will continue unless and until we see federal PBM legislation enacted. There is some federal PBM legislation in the works now, including the PBM Price Transparency and Accountability Act. So that's pending in Congress, and it seeks to limit certain PBM pricing and contracting policies that impact group health plans, but we'll have to see if that makes it to the finish line. Next slide. So what should an employer plan sponsor do now? Well, certainly when this new guidance is released, review it and begin preparing to implement it once it's finalized. This means employers will need to consult with their service providers, including their PBMs, to ensure they'll assist the employer in implementing the requirements, the prescription drug MRF posting, and you should also be looking at your contract terms too. You want to make sure they're agreeing to fulfill those obligations in the contract. And employers should also be ensuring that their fiduciary governance practices are in order, particularly with respect to selecting and monitoring service providers and their compensation. Employers should continue to monitor any ERISA fiduciary breach litigation and federal PBM legislative activity. And finally, I would expect a lot of activity in the prescription drug space in the coming year. We don't know how some of the new developments, we heard of Trump RX. There's also manufacturer direct to consumer, and now even more recently, direct to employer marketing for certain drugs. But whether there'll be those options will be available to sponsors in an effective and compliant manner, we don't know. But we do hope and expect that these initiatives overall will create a more competitive healthcare and prescription drug marketplace, and that will in turn lower prices. So there's a lot to watch here. I just threw out a lot of information at you, but please stay tuned. And we do have publications, our transparency publication, and also ERISA fiduciary governance publication to assist you with fulfilling your obligations.
Great. Thanks, Carol. Yeah, prescription drug and transparency in general, those are definitely going to be topics to look forward and kind of keep your ears open for 2026. And now I'm going to take us through just some general kind of, potential agency guidance that we're looking to see in 2026 and just some additional hot topics that employers and plan sponsors want to consider. So this first one here, I think, is something that many of you have heard about. So this is the expiration of the enhanced premium tax credit, so the subsidies. This was obviously a large player in the government shutdown, so we want to kind of give an update of where this stands. And so for those that aren't familiar, what are those enhanced premium tax credits? So originally when we had, the premium tax credits, or think of it as the subsidies on the marketplace, those were for people with incomes of 100% to 400% of the federal poverty level. So those were the original subsidy kind of income requirements. Then back in 2021 with ARPA, that maximum was eliminated. So even folks who had incomes above 400%, they could qualify for some level of premium tax credit as well. So that was the enhanced part of it. Those rules are set to expire at the end of this year, unless we have an extension. So again, what's been happening? As I said, it was a big player in the government shutdown. One of the compromises that were made to lead to the end of the shutdown is congressional leaders did agree to hold a vote on whether or not these enhanced premium tax credits would be extended past 12/31. So where do we stand? So last week the Senate held a vote. It did not pass. And then this week is when we were looking to see the House vote on it. We had some late night developments or end of the day developments from the House, where basically the House is using what we're calling a procedural move to force a floor vote. However, that floor vote is not going to happen until January. So the House essentially is not going to vote on it for quite some time. We thought they might vote this week. That obviously is not happening. So where we stand today is Congress is still negotiating, right? So whether or not this extension will happen is still up in the air. Although I think many agree that it's probably unlikely we'll see an extension, but we don't know, right? We won't know until we know. So as it stands today, the credits are set to expire at the end of this year. Again, barring any sort of unexpected development between now and potentially a vote in January. So this definitely can impact, those who were maybe still hoping or expecting to receive those enhanced premium tax credits for their marketplace coverage. I've got an important note here at the bottom. If someone is losing a subsidy or the prices are changing, they were expecting to have that tax credit and now they're not going to have it in 2026. That does not create a mid-year election change event, or sometimes called a qualifying life event, for an employer or for an employee to join the employer plan mid-year. And this is kind of a common situation that gets confused. We actually included this as our frequently asked question in our Compliance Corner newsletter that just came out today. So definitely take a look at that. We'll go into more detail. But I just wanted to pull that out because I think this is a topic that a lot of people are asking about if they have employees who are going to be losing those subsidies. And then the next topic here, with the DOL electronic disclosure rules. So I think many are aware that in certain circumstances, employers can distribute, annual notices or other required plan documents electronically instead of having to deal with hard copies or, mailing those to employees. So the current rules, as they stand, basically say that the only way an employee can receive electronic notices is if they have work-related computer access as an integral part of their job, or if they consent to receive these notices electronically. The DOL, fortunately, is looking to modernize this process, and it would be similar to some changes we saw in 2020 in the retirement plan world. So basically, it's sort of recognizing, right, society has changed. People are glued to their phones. Most people are going to have email addresses and internet access. And so accessing documents electronically is much easier than years before. Employers, if you are one that still prints and mails documents, that can be very costly. So a change in these rules would really help employers save money. So we don't know what this will look like yet, but the hope would be that it would create a default to electronic disclosures. So, first step would be to receive those electronically, and then an employee could opt out of receiving those electronic notices or documents and get paper instead. So, I think that would be a welcome change to employers and plan sponsors. We'll just have to wait and see what that looks like. Right now, we're seeing the target date for proposed regulations would be May of 2026. So, we'll kind of keep our eyes open for what that may look like. And then a couple miscellaneous updates. Fertility benefits. So, one of the campaign promises from the Trump administration and then a February executive order was increasing access to IVF. And so in October, we did get some guidance, basically giving some options for employers on, potentially ways to increase that access. So one option is offering standalone, fully insured fertility coverage to all employees and even those who are not enrolled in the employer's group health plan, as long as it meets certain criteria to make it be considered what we call an accepted benefit. The key here is, the policy needs to be issued as a separate policy as it stands. So that's why a self-insured plan for this fertility coverage would not be allowed currently. Again, always going to be subject to change. Another option presented in the guidance for fertility expenses is an EBHRA or an accepted benefit HRA. Again, it's another way to potentially reimburse fertility expenses. In that case, it would only be for employees who are also offered the group health plan, so little difference in eligibility. Opening access to common fertility drugs, potentially available on Trump RX. We'll see what that looks like or what actually becomes available, but that is something that we may see in 2026 as well. So again, the theme of increasing access. And then finally, federal paid leave initiatives. Molly walked us through the patchwork of state laws here, and it can definitely be confusing for employers that have employees in many different states. So this is just kind of some potential working groups to work through ways to more streamline the rules state by state, or to potentially even offer grants to states that are kind of working to make this easier for employers. It does not require states to offer this coverage. It's just trying to make it more efficient. So we'll kind of wait and see what this looks like in 2026 as well. But again, definitely a hot topic to keep a lookout for. And now we're going to close out with some year-end reminders and benefits housekeeping with Ben.
Hey, thanks, Kelly, and good afternoon, everyone. There's sure a lot of activity in Washington going on, so lots to look forward to in the new year. But before we wrap up, let's take a quick look at some of those outstanding compliance tasks that you might need to address soon, if you haven't already. NFP has a guide on each of the requirements that I'm about to mention. So again, please ask your NFP consultant for a copy if you'd like more information about anything I'm about to discuss. Up first is the attestation for your group health plan's compliance with the gag clause prohibitions. This is the third year that plans are required to attest, so hopefully this isn't a new requirement to anyone joining us today. But if it is, group health plans are prohibited from agreeing to contracts that include what are called gag clauses. So these are terms that restrict the plan from sharing certain cost and quality data with their members or with referring providers. There are also terms that restrict the plan from accessing certain claims data. If your health plan is fully insured, check with your carrier to make sure that your carrier will attest on behalf of the plan. If you're self-insured, you should have a conversation with your TPA or your other service providers like your PBM to understand if they'll attest on behalf of your plan. Ultimately, if your plan is self-insured, which includes level funded, it's up to you as the employer to attest. So if your TPA doesn't attest, or if they'll only attest to parts of your plan, but not all of it, then it's ultimately going to be up to you to attest or to fill in the gaps on your TPA's attestation. Those attestations are due by December 31st. We've included the link on the screen here to CMS's website where you can go ahead and complete those. ACA Form W-2 reporting is also coming up. Employers must file their W-2s with the Social Security Administration every year by January 31st. If you filed 250 or more Forms W-2 last year, you're required to report the aggregate cost of employer-sponsored group health coverage on each covered employee's W-2 this year. So that includes the total value of employer and employee contributions together for coverage. The cost of coverage is reported on box 12 of an employee's W-2 using code DD. So again, check with your payroll vendor to determine if they're handling this requirement. If you're doing payroll or W-2 reporting in-house, just make sure you know whether you're subject to this requirement so you can prepare accordingly. Next up is imputed income. This is something that needs to be on your radar if your business offers group term life insurance to employees, or if your employees can elect any health benefits for their domestic partners. For group term life insurance, any coverage over $50,000 is taxable to the employee. You may also need to tax the full value of coverage if you're for any key employees, if your plan is found to be discriminatory, if it doesn't pass those group term life insurance non-discrimination tests. And then health coverage for a domestic partner is also taxable unless a domestic partner qualifies as an employee's tax dependent, which is pretty rare. So the way to make sure employees are taxed appropriately on this coverage is by imputing income. Basically, the employer adds the cash value of a taxable benefit to an employee's gross income, then withholds taxes based on that additional income. If you've been imputing income throughout the year and withholding those taxes on the value of this coverage all through the year, then you're probably good. If you haven't been doing that, then you'll need to impute income for employees and then reconcile those taxes at the end of the year so they can be reported accurately on Forms W-2. So again, as with the W-2 reporting, check with your payroll vendor and determine if you still need to impute income before the end of the year. If you do, it's probably a good idea to communicate to your employees what you're doing so that they're not caught by surprise if they get a smaller paycheck than they're expecting because more taxes come out at the end of the year. NFP did publish a calculator earlier this year to help employers to determine the fair market value of domestic partner coverage. So, I invite you to ask your NFP consultant to show you that calculator and show you how it works if you're looking for a little additional help on imputing income. And then last on our year-end to-do list is to double check your health plan's HIPAA notice of privacy practices to make sure that it's up to date. Updates are due by February 16th. And we've kind of seen the HIPAA privacy requirements whipsaw back and forth in the last few years. There was a substance use disorder rule that the Biden administration issued in 2024. There was also a reproductive healthcare privacy rule. The healthcare privacy or the reproductive healthcare privacy rule is no longer being enforced. It's been set aside. So you don't need to update your privacy practices for that. But the substance use disorder rule, it was primarily targeted at treatment facilities that receive federal funding. However, it does require all covered entities, so group health plans, to update their notices of privacy practices just to include certain information about their use and of substance use disorder treatment records. So check with your HIPAA vendor to make sure that your plan's notice is compliant. You still have until February 16th, so there's still plenty of time to get that up to date if you need to. And then as we reach the end of our presentation here, just want to remind you that HSA annual limits are increasing for 2026. Sharon also mentioned that the Dependent Care Assistance Program, those annual limits also increase as of January 1. Employers don't have to adopt those new limits. And if you have historically had trouble passing the non-discrimination test, you may want to keep your limits as is for 2026. There we have it. We're at 3 o'clock Central. Kelly, I'll pass it back to you.
All right, thanks, Ben. Yeah, so since we're at the top of the hour, thank you everyone for joining us. I know we covered a lot. As always, take a look at those slides in the recording once it is sent out and let your consultants know if you have questions. And otherwise, we hope you all have a great holiday season and thank you so much for joining us. And I'll pass it back to Amber.
All right. Well, thank you to our NFP Benefits Compliance team for sharing your valuable time and expertise with us today. To reiterate, today's presentation has been recorded. We'll be sharing the recording in the follow-up email and on the NFP website. If there are any portions of this call that you missed, by Monday you'll receive an email with a link to the full recording. The PowerPoint slides used during this presentation will be shared in the same email. At the end of this call, a survey will populate in a new window. Please take a brief moment to complete the survey, as it lets us know what topics are important to our listeners and helps make our education program as current and relevant as possible. That concludes our webinar for today. Thank you everyone for joining us and have a great day.